Okay, good morning, everybody. Today, I'll be talking on osteomyelitis. It's an important topic from exam point of view, okay? So osteomyelitis, it is defined as an inflammation of bone caused by an infective organism, okay? It is not just inflammation. Infective organism should be there to cause the inflammation, okay? An infection can be limited to a single portion of the bone, or it may involve the numerous regions of the bone. It may involve the marrow, the cortex, the periosteum, and the surrounding soft tissue, okay? And the organism involved could be a single organism, or it could be polyorganisms, okay, especially in immunocompromised patients like diabetes, okay, and those on steroids, on who are using IV drugs, okay. So in them, they can be polymicrobial organisms. So classification based on the duration of symptoms is acute, subacute, and chronic, okay. Chronic means if the infection goes beyond 6 weeks, okay, and subacute is a very indolent type of cause, okay, is not acute, not chronic. Indolent means slow type, fever also, there may not be fever, pain may not be much, and the blood counts, ESR may not be elevated, okay. So today we will talk about acute and subacute, and chronic we will talk in tomorrow. So, talking about acute osteomyelitis, okay? So, when you say acute osteomyelitis, we usually understand that it occurs in children, okay? Because the mechanism in which it occurs in children and adults is quite different, okay? In children, it is mostly the hematogenous routes. So, infection is somewhere in the body, and from there, the organisms coming into the blood, bacteremia, and is lodging in the bone, in the metaphyseal area, okay. In adult, this is only about 20%, but in children, this is the most common mechanism. It occurs this way. So when we talk about acute hematogenous osteomyelitis, it means in children, okay. In adult, it is quite different. It doesn't occur that way. How it occurs is the direct inoculation of the organisms. Like suppose you have an open fracture, the organism there gets directly to the bone, then the infection starts and you get osteomyelitis. Similarly, if you do an orthopedic surgery, putting an implant, okay, then the organisms are lodged in the implant, which is stainless steel or titanium, then the infection starts. So the mechanism is quite different. And when you say acute hematogenous osteomyelitis, you must understand that we are talking about in children, okay. So what are the predisposing factors, okay? Malnutrition and general debility. So why does the infection occur? It's always the two things. One is the host, okay? How strong is the host, okay? And the virulence of the organism. So if the organism is more viral and the host is malnutrited, or he's not that immunologically strong, then he will get the infection, okay? But if the host is strong, okay, then the organism is less virulent, then we get a subclinical case, like which will talk subacute osteomyelitis, okay. So the other factor, all is actually immunocompromised condition. So diabetes, corticosteroid administration, immune deficiency, immunosuppressive drugs, okay, all this means immunosuppression, okay, and venous stasis in the limbs, peripheral vascular disease, and trauma. If the circulation also is not good in the limb, you're also prone to infection, okay. So these are the predisposing factors. So the etiology, the organisms, okay, the most common is Staphylococcus aureus. The next is group A beta hemolytic streptococci. So while treating, we always consider these two organisms, strep and strep, okay. The other is group B streptococcus, especially in newborn. So it could be Streptococcus pneumoniae and also H. influenzae. But nowadays, due to this H influenza vaccine, the incidence of osteomyelitis due to this organism is less. Okay, it's mostly staph and strep, and we have other organisms, gram-negative organisms like E. coli, Pseudomonas aeruginosa, especially in those which are immunocompromised, like IV drug users. And other is the Salmonella typhi. Okay, so if a person with sickle cell disease gets osteomyelitis, is most probably due to Salmonella typhi, because in patients with sickle cell disease, Salmonella typhi, the organism is found more in the patient with sickle cell disease. So if the patient with sickle cell disease gets osteomyelitis, the common organism is Salmonella typhi, but it does not mean that Staph aureus may not be found. Okay. So now we just look at the blood supply, okay, of this long bone. So blood supply of long bone is mainly, one is the nutrient artery system, okay, one is the periosteal system, and the third one is the epiphyseal metaphyseal blood supply system. Okay, we'll be talking about this because it is important to know the etiopathogenesis of osteomyelitis. Okay, so if you look at this, so this is a bone of maybe infant or less than 2 years. Okay, so what we see is this is the growth plate, and these are the metaphyseal blood vessels. Okay, crossing the physis. Okay, so this is metaphysis, this is the physis, this is the epiphysis. Okay, so what we see is that the blood vessel is traversing this physis. So we understand that if there's an infection, so it can pass through and go to the epiphysis. But in older children, maybe more than 2 years, they have a different system. Okay, the metaphyseal blood supply system just limits to the metaphysis, and it does not go through the physis. To supply the physis, there is a different artery system, the epiphyseal blood supply. Okay, so this is what we just talked about. In less than 2 years, this metaphyseal metaphyseal artery system crossing the physis, and in more than 2 years does not cross. And it forms in older children, it forms a very peculiar type of system here, which is known as the hairpin loop. Okay, if you look at this, it is bent, okay, this way, it forms loop. So this artery system forms loop and goes to the venous sinusoid and then the venous system. So the significance of this is that there is blood stasis in this area, in the metaphyseal area. So if there is blood stasis, there's more chance for the organisms to colonize in this area. Also, the oxygen tension in this area, in this hairpin loop area, is less. So more the bacteria can colonize there. Okay, so the infection starts from this metaphyseal area. Okay, but the physis prevent them from going to the epiphysis, which is not so in the children less than 2 years. So if a small child, infant, okay, less than 2 years, maybe a neonate gets osteomyelitis, it is very difficult to distinguish whether it is osteomyelitis or septic arthritis, because once it traverses this physis, goes to the epiphysis, then the joint is involved. Okay, so in infants, it's quite difficult to distinguish between osteomyelitis and septic arthritis. Okay. So now talking about the pathogenesis, how it goes. So this is both for the acute and chronic. Okay, this process goes on from the acute to the chronic. But if you can stop it, then it just remains in the acute. Okay, it doesn't go to the chronicity. So what happens is, this is the metaphyseal area, this is the physeal area. Okay, so there's infection somewhere in the body, maybe from your discharge, maybe caries tooth, or maybe some boil in any parts of the body, and the organisms come and they colonize in the metaphysis. So once it colonizes in the metaphysis, what happens is then there's a reaction, inflammatory reaction, okay? And when there's an inflammatory reaction, the exudates form, okay? And there's cell debris, and ultimately the pus forms, okay? So here the pus forms in the metaphyseal area. And once the pus forms, then the patient gets the pain, okay? Because getting pus in the bone is quite different from getting pus in the muscles, skin, okay? Bone is a rigid compartment. So if there's pus, then the patient, the intra-osseous pressure increase and the patient will have severe pain, okay? So the patient will have severe bone pain. Now the fate of the pus, how it goes, okay? Now the pus, it can break from this cortex and it percolates down the periosteum, and that is known as a subperiosteal pus, okay? The pus, the periosteum in the children is quite loose and thick, so it percolates down, okay? The other is, it can go directly to the medullary cavity. The other is from this area, it can go directly to the joint. And especially in this humerus and the hip joint, where the joint capsule is not limited to the epiphysis, but it comes way down to the metaphysis, the infection from the bone can directly go to the joint, okay? So the treatment part, we have to stop this process, okay? Either give antibiotics, the symptoms subside, or you make some drill holes and percolate, remove the pus, then it stops, the disease process stops there. It doesn't go into chronicity. But if you are not able to do that and the disease process goes on, then it leads in chronic osteomyelitis, okay? So what happens if this disease process keeps on going, pus forms, and due to the pressure rise, the blood supply to the bone is diminished, okay? So once it's diminished, slowly the bone starts to die, okay? And it is said that the dead bone can be seen microscopically at the end of 1 week, okay? Now, this reaction keeps on going, okay? The dead bone is there, and then the infected granulation tissue surrounds this dead bone. And when it's the granulation tissue, the infected granulation tissue surrounds the dead bone, it is known as the sequestrum, okay? Sequestrum is not just a piece of dead bone, but dead bone surrounded by infected granulation tissue, okay? Still further, there's other reaction going on. Then the body tries to seal that infection, okay? What does it do? It forms the new bone, and the new bone surrounding the sequestrum is known as the involucrum, okay? Is known as the involucrum. Again, if the disease process is not stopped and it keeps on going, what happens is the dead bone within this involucrum, this forms small spicules, and they tend to come out. They come out from the sequestrum, from the hole, and the hole is known as the cloaca, okay? The small debris and spicules, they come out from the sequestrum. Now, from the cloaca, it comes out, but it still lies within the skin. So after a long time, the spicules of bone comes from the sequestrum to lie beneath the skin, but ultimately it also comes out from the skin, okay? And that time a sinus is formed, okay? So know what is sinus and know what is cloaca, okay? So this is the pathogenesis. So you all have to understand this. So this is from the acute to the chronic. So if you stop at this area, it doesn't go into chronicity. But if you cannot stop due to the patient coming late to the hospital or your inadequate treatment, if it goes in chronicity, so then the sequestrum forms and also the involucrum forms, okay? So this is what I just explained to you, okay? So just remember that pus formation takes place in second to third day of bone within the bone. And the pus spread along the Volksmann canal to the surface, okay? To lie under the subperiosteal region to form the subperiosteal abscess, okay, and sequestrum microscopic evidence of bone death by the end of 1 week, okay. So this also I've just explained. If the infection is not controlled, a nidus of infection remains, which may lead to chronic osteomyelitis, okay. So now the acute osteomyelitis in adults, which I just said, this hematogenous osteomyelitis in adults is just 20%. And if it occurs, okay, in adults, mostly it doesn't go to the long bone. It goes to the vertebral bodies, okay. So hematogenous osteomyelitis is uncommon. There's less periosteal reaction, prone to fracture, and occurs in vertebral bodies, okay. The other method is direct inoculation of the organism in open fracture or in the surgery where an implant has been put. So clinical features. There will be severe pain, malaise, and fever, okay. The patient may even look toxic, okay. And the child will not be able to bear weight and will not walk, okay, due to pain, and that is known as pseudo-paralysis, okay. And there may be a recent history of infection, maybe a septic toe, sore throat, ear discharge, but in most of the cases, you do not find, okay, the primary source, okay. The patient just comes, has pain in the region around the knee, okay, or maybe the shoulder, okay. So, and you will not be able to find the primary site of infection, okay. And most of the time, there's also a coincident history of trauma. Somehow, the osteomyelitis process has been going in the bone, okay, but the patient has not had clinical features like fever and pain, and suddenly the patient maybe just falls down or something hits to his body parts, then the patient will come and the patient will slowly say that it is due to trauma, okay, but sometimes it is coincidental, okay. The disease process is going on, it has not showed symptoms, but the patient sustains trauma, then the patient will say that it is due to trauma, okay. So sometimes it is also coincidental, okay. And infants, you may not find all these features, okay. You just find the failure to thrive. The patient is, the infant is not thriving, even though you are feeding well, okay. And there may be irritability and bony tenderness. So on examination, the patient is ill-looking, pyrexia, tachycardia, the limb is held still, okay, and the signs of inflammation, red, swollen, warm, tender, okay. And this is in the long bones of the children, and in adults, okay, the spine is involved, so you'll find some tenderness in the spine, okay, in dorsal lumbar region, okay. So the investigations. Okay, first week, if you do an X-ray, you'll just see the soft tissue swelling, okay. The periosteal newborn formation, okay, that is seen in the second week. And late sign is regional osteoporosis, okay. Regional osteoporosis means in the bone, you'll see a lot of trabeculae, okay, showing that the bone is metabolically more active, okay. So if you look at this X-ray, okay, so the first X-ray is 2 days after the symptoms began is normal, okay. So the patient comes, you take an X-ray, he has history of fever and he has history of pain in the proximal leg. You took an X-ray, you just see like this, okay. But the patient still had pain and comes to you in 2 weeks. Now in 2 weeks, if you take the X-ray is like this. So what you see is already there is a periosteal newborn formation, okay. So here actually there was subperiosteal pus, and later then the newborn formation took place. So this is the periosteal newborn formation, and here you see cavities, okay. This lucent area is all cavities, okay. And here still the patient, then this X-ray was taken at a much later date. Now look at the periosteal reaction. It has increased and the cortical bone has thickened and the areas of lucency has increased. And if you look at this whitish area, this small area, this could be a sequestrum, okay. The second sequestrum is a dead piece of bone, looks totally white, okay, because it is not metabolically active, decalcification does not take place, calcium is entrapped, and its you see is as very white. Okay. So the other investigation is, you can see the subperiosteal collection of pus in the ultrasound, but it's very difficult to detect. Okay, you need a really expert to do this. And the best investigation is MRI, which we can do in our setup. Okay, because it differentiates soft tissue infection from bone infection. So it just clarifies, okay, whether the pus, okay, whether the bone has been infected, pus has been formed in the bone, and the pus is percolating from bone to the soft tissue. Okay, so that is osteomyelitis. Okay, but sometimes it may just be a soft tissue. There may just be a pus in the muscle which has been injected exogenously, and it is just in the soft tissue in the muscle, and it has not touched the bone. Okay, so it helps to distinguish whether it is osteomyelitis, okay, or it is just a soft tissue infection. So we most of the time do this MRI in our setup. The other investigation is this bone scan. Okay, and the bone scan is done using this active tracer agents, technetium-99 or indium-labeled leukocytes. What you see is you inject these active tracer agents intravenously, and you just take these photographs, okay, like the X-rays, and there you can see the uptake. Okay, which bone is very metabolically active, there'll be a uptake of these agents. Okay, and so you can see in that way. And this is the bone scan. Okay, and when you do this bone scan, there are 3 phases. Okay, and increased activity is seen in both in perfusion and bone phase. Okay, so other investigation is you can just put a needle inside and take aspirate and do a gram state and culture and sensitivity. Okay, a positive in 60%. Blood culture we usually do not do, but if you do, is positive in just 50% of cases. Okay, total counts is increased, that is the WBC is increased, and CRP is positive in 12 to 24 hours. Okay, initially the CRP will rise, then slowly the ESR will rise, which increases in 24 to 48 hours. And this is important because this is a guide to treatment. Once you start the treatment with the IV antibiotics, we do this regularly in 3-4 days to see that whether the CRP ESR, which was initially raised, is coming down. Okay. So what is the differential diagnosis? Okay, so the patient comes, has fever. Okay, he has pain in the proximal tibia of distal femur. You examine this swelling, it is warm. So it could just be a cellulitis. Okay, infection of the skin and subcutaneous tissue. Okay, other is the arthritis, the infection of the joint. Okay, and other is acute rheumatism, so of the rheumatic fever, where you have this migrating polyarthritis. Okay, the other differential diagnosis is scurvy. Now this, to know this, you have to do an X-ray. Okay, when you do an X-ray, you'll see that the subperiosteal area is elevated. Okay, so in scurvy what happens is there's defect in this collagen synthesis. The capillaries are very fragile, and there's hemorrhage under the subperiosteal region. In children is very loose and thick periosteum, so then there's hemorrhage and the periosteum is elevated. But in the X-ray, when you see that it's elevated, but you do not know whether it is blood or whether it is pus. Okay, so in X-ray the differential diagnosis could be scurvy, but in scurvy you will not have fever, you will have no bony tenderness. Okay, so now the treatment. Okay, how you go about the treatment. So supportive treatment for pain and dehydration. The pain is severe. Okay, so you have to give analgesics, and the patient is sick, has fever, he will be dehydrated, so you have to rehydrate the patient. Okay, and if you move the limb, it is very painful, so you'd want to splint it. Okay, you can just put slab, or you can put a skin traction. Okay, and then you can start the antibiotic therapy. You can start empirically. You don't have to wait for the results. Okay, before starting antibiotic, you send the pus culture or any aspirate culture. Then you can just start the antibiotics. You do not wait for the culture to come back. Okay, then the other form of treatment is surgical management, which we do once you initiate the antibiotic therapy and you're convinced that the patient is not getting better. Okay. So antibiotic therapy, the antibiotics should not await results of culture and sensitivity. Initial antibiotic is targeted at Staphylococcus, and IV antibiotics usually given for 2 to 4 weeks. Okay. Then once the CRP and ESR values improve, then you can give oral antibiotics. That also you give for 3 to 6 weeks. So once you are treating a patient with osteomyelitis, you will have to have antibiotics for 1.5 to almost 2.5 to 3 months. Okay. So it's quite a long time you have to take the antibiotics. Okay. If you do not take adequate antibiotics during this acute osteomyelitis, then it will go into chronicity, chronic osteomyelitis, which is very, very difficult to treat. Okay. So antimicrobial therapy, definite one is done due to culture and sensitivity. Okay. And different hospitals or different countries have different regimens for starting these antibiotics. Okay. This one I have taken from the Applis, and it gives like neonates and infants up to 6 months is flucloxacillin, a combination of flucloxacillin and third generation cephalosporin like cefotaxime, ceftriaxone. Okay. And if there's a gram-negative organism, gentamicin. Okay. In children 6 months to 6 years also is the same, flucloxacin and third generation cephalosporin. And older children and adults, flucloxacin and fusidic acid. Okay. And for immunocompromised patient, empirical treatment with broad spectrum antibiotics. Broad spectrum again means the cephalosporin. Okay. Could be second generation, could be third generation. So when you move from second generation to third generation, there's more coverage of the gram-negative organism. Second generation, more coverage of gram-positive organism. Okay. And the other is you can use vancomycin also. And vancomycin is reserved if you have methicillin-resistant Staph aureus. Okay. So if you isolate the bug as methicillin-resistant Staph aureus after culture and sensitivity, then we switch to vancomycin. Okay. But some patients are sensitive to vancomycin. Okay. They have some allergic reaction to vancomycin. Then in that case, we switch on to linezolid. Okay. Surgical management. Okay. This is indicated if the clinical features do not improve within 36 hours of starting the treatment. If there are signs of deep pus, okay, then you have to surgically manage the patient. Or if you put a syringe and pus is aspirated, okay, then you have to surgically manage the patient. Okay. And how you manage it? Okay. So you have to drain the pus. Okay. We use tourniquet whenever possible. Means it's like a blood pressure cuff. Okay. We put it, suppose you want to do an operative procedure in the tibia, then you put it in the femur. If you want to do in the forearm, then in the arm. Okay. But you cannot put tourniquet for the procedures in the femur and the humerus. So if you inflate the cuff, then the field of surgery is avascular. Okay. So it's easy to visualize your surgical field. Okay. But you do not exsanguinate, means usually when we put a tourniquet, before inflating it, we put like a rubber bandage, and exsanguinate means, now suppose you are going to operate in the tibia and you have put the tourniquet in the femur, you elevate the limb so that all the blood from the foot, leg goes, okay, goes to the thigh, and you have a clear field in the tibia. But in this, you do not exsanguinate, means do not squeeze the blood from the distal to the proximal part. Okay. Then you incise the peristome longitudinally. In children, the peristome is very, very thick. Okay. Then you drill holes. Okay. And let the pus just accumulate within the bone come out. And if there's a lot of pus, you can also make a cortical window. Means you drill multiple holes and remove a small piece of bone so that there's quite a big hole in the bone and the pus can come out easily. Okay. But once you make a cortical window, you have to immobilize the limb. Otherwise, that portion can fracture. Okay. That portion of the bone can fracture. Then you do a pulsatile lavage with saline and close the skin loosely over drill. Okay. So this is one of our patients. Okay. So he had osteomyelitis of the fibula. It was detected early, and since he did not improve with this IV antibiotics 48 hours, we plan to operate him and remove the pus. Okay, so this is the fibula. Okay, so what you see, this is a closer view of that same picture. That this is the bone, this is the periosteum which I have incised longitudinally. Okay, and drill the holes. Okay, here I drilled a hole and there was no pus. I went more proximal. This is the metaphyseal area. Somewhere around here is the head of the fibula, and this is the metaphyseal area. And when I drilled, the pus came out. Okay, I went further up, the pus came out. So now this case, having done this surgical intervention, the patient improved and the disease process did not progress to chronicity. Okay, so the disease stopped where the disease stopped there itself. Okay, after the surgical intervention. Okay, had this not been done or there was a delay, it could go into chronicity, and chronicity is very difficult to treat. Okay, so the complications is epiphyseal damage, the growth plate damage. So it could live. If the infection from the metaphysis goes to physis, if it's damage of the physis, then there can be growth disturbance and maybe short limb. If the infection goes to the joint, then you can have suppurative arthritis, septic arthritis. Okay. Now, the diseased bone is weak, so there could be a pathological fracture. And if inadequate treatment, late treatment, the disease process can go into chronic osteomyelitis. Okay, which we'll talk tomorrow. Now we'll talk about the subacute osteomyelitis. Okay, and Brody's abscess is one form of subacute osteomyelitis. And as I told you, in this case, the organism is less virulent and the host is more powerful. Okay, so what happens is the host defense mechanism overcomes the bacteria or infective organism. Okay, so the infection is limited. Okay, and it is confined. Okay, the bone abscess by a zone of sclerosis. It is confined to that area. Okay, from there it doesn't go. It doesn't come out of the cortex or goes down to the middle cavity or goes up to the joint. Okay, so it is confined. Okay, and the clinical feature is very indolent. Okay, the patient will have pain. Okay, but it is not severe for several weeks. Okay, and temperature is usually normal. If you just examine it, it may not be that warm, or it may just be a normal body temperature. The WBC counts is not that elevated, and ESR may or may not be elevated. Okay, so that is the Brody's abscess. And if you take an X-ray, look at this lytic lesion. Okay, this translucent area surrounded by a zone of sclerosis. Okay, so this is Brody's abscess. It will just remain like that. Okay, and if you put a needle and take out the infective material, you will find a seropurulent, not pus, but a seropurulent type of discharge. Okay, and the treatment of this is you just curate it. You give antibiotics and you just curate that. Okay, so surgical evacuation by curate under antibiotic cover is the treatment. Okay, and with this we finished this class on acute osteomyelitis.